Hello, everybody, and good afternoon. Welcome to this session. I'm Torsten Olbers from Norrköping, and I'm also chairman of the Committee for Surgical Science for Swedish Surgical Society. I have the honor to chair this session and moderate this session, and it's going to be in English. That's a prerequisite for this session because we're going to have the prizes with a joint venture for Swedish Surgical Society and BJS. As we know, Swedish Surgical Society is a strategic partner for BJS Society, and it's papers that's submitted to BJS or BJS Open. As I said, this is a generous thing put up where we have this financial support from BJS Society. It's only members in Swedish Surgical Society that can apply for this. So it's important to know that this is a benefit of being a member. It's really good prizes. It's a first prize of 3,500 euros and it's a second prize of 1,500 euros. There were 4 to 6 abstracts normally yearly, and they are sent in April, May somewhere, and then they've been submitted to full paper. So in the end of July, we had a list with 6 papers that were assessed by the chief editor of BJS, Des Winter, and BJS Open, Ville Salenius, who together with a representative from KKF, assessed the papers. It's important to know that if you have submitted here, it's not a guarantee to get published, but I think there's a good chance for the papers of today. We will have 5 minutes. It's a 1 hour session, and we will have 5 minutes for each presentation. And we aim at having 1 to 2 questions. So I think it's really good if we have this interaction. And there's a microphone out there also, but I will also try to figure out a question. But if we have the time, we will have 1 or 2 questions after each presentations, and the winners will be announced at the end of the session. I noticed it was put on the doors here, but this is a recorded session, so you might break on internet after this. So these are the 6 very interesting papers that have been submitted here, and I think it's a really good mix of different methodology, different approaches, different questions. It's qualitative, it's quantitative, it's explorative. So I think we will have a good breadth of papers that we're going to listen to today. So, without further notice, I would like to welcome My Blom from Dalarna, who put together a study with a paper with the name "Female and Male Gender Surgeons Differ in Personality Traits," a Swedish cross-sectional study. Really interesting topic. You have quite a lot of international attention, didn't you?
Yeah, not for this one, but this is a follow-up study. Yeah. So thank you very much for the opportunity to start this session. And I'm going to talk about something somewhat controversial, which is gender differences in surgery. And there has been quite a lot of evidence suggesting that female and male physicians practice medicine differently in terms of how we follow guidelines, communication style, and patient selection for different surgical and other procedures. And when it comes to surgery, as you can see, a lot of publications indicate better outcomes for female surgeons in terms of 30-day mortality, readmission rates, and yes, length of stay. And we published an article last year indicating better or fewer complications for female surgeons and shorter hospital stays and somewhat longer operating times. And this kind of research is popular for news media, and it's not rarely mentioned in this way. Are women better surgeons than men? And this is not really the case, and it evokes emotions. So please don't be defensive. Let's be curious. Why do we have this kind of results? And can we find an explanation? And one possible explanation is differences in personality traits. And we asked ourselves, do female male and surgeons differ in personality traits? And this is a cross-sectional study in which Swedish general surgeons were invited to do a survey, including a personality test with something called the Big Five Inventory. I'll come back to that. And this survey was answered autumn 2022 and autumn 2023. And what about the Big Five Inventory? Some of you might have seen Anders Hansen's TV show this autumn, and you know all about it. You've done your own tests, etc. But if you don't know about it, the theory is that we have 5 big personality traits, and we all score differently within these traits. And we talk about openness, we talk about conscientiousness, extraversion, agreeableness, and neuroticism. And depending on our score, we can explain our personality and how we react. So what did we find? Well, we had 223 responses or respondents, and somewhat more male surgeons, 54 to 46%. And the male surgeons were in general somewhat older. They had longer clinical experience and worked to a little greater extent at rural hospitals. So what did we find? Well, female surgeons, they score higher in openness. Female surgeons score higher in conscientiousness. We see the same tendency for extraversion and agreeableness and neuroticism. And if we adjust for age, all apart from openness remain significant. And as you can see, surgeons in general are rather conscientious and open and agreeable. And a common reaction to this kind of research from the start, I've done this for quite 1 year now, is that why do you do this kind of research? And does the sex of the surgeon really matter? And I think it's about surgical safety, and we talk about robotic surgery, we talk about nice instruments and how to operate and expensive measures, etc. But what about the individual surgeon? Some of us are better surgeons than others, and I don't think this is about gender. This might be a selection process. But if we can look at the surgeon and characteristics like, for example, personality, decision-making, and surgical technique, we can find factors that can be included in surgical education and recruitment. So back to the study. What did we find? Well, if we look at these 5 traits, we found that female surgeons, they score higher in all traits apart from openness, or higher in all traits, but it's significant for all of them apart from openness. Thank you.
Thank you very much, Mi.
Thank you.
Is there a question in the audience? Linus, please. Mike?
I'm just asking, are there any studies that describes what traits are beneficial for high quality surgery?
Not yet. This field of area of research is rather new, and still when you publish articles within the field, the first reaction is often, this is not true. And usually in surgery it's like, oh, interesting, what can we learn from this, and how can we use it? But still this is not true. So we know nothing. There are studies on surgeons in general confirming our results, but we don't. This is one of the first studies in the field on gender differences in surgery and personality. So that's interesting. I think there is a lot of ongoing research. So in the last 10 years or so, we will know more about it, yes.
Do I read you right also that this is one thing you did to explain why you could see other differences in more type of complications and those things that you published before?
Yeah. And we found one of the interesting findings from the previous studies is that we found a difference in surgical complications. And surgical complications is happening in the operating room. It's something we're doing when we're operating. It might be a question of decision making or perhaps personality, how you communicate. And we've also found a longer operating time for female surgeons. And why do we have longer operating times and fewer complications? Is it a question of that you're neurotic, you're afraid of what's happening or the risk of complications, you take an extra look? Or are you more conscientious that you actually follow all the steps when you're doing your Liechtenstein open hernia operation, for example? So this is not, it's a tiny study and it's not at the top of the research pyramid, but we have to, it's a beginning, and I'm looking forward to continue this kind of research.
I just need to ask something that I thought about. Now we know the difference between male and female surgeons, but how does that compare to the general population?
Internationally, there are a lot of studies comparing female and male, and not a lot, and in all countries, female surgeons score higher in neuroticism.
Yeah, but are there features just being a surgeon? So if you're a female surgeon, you compare it to a female who's not surgeon, and a male surgeon compared to a male in the society.
Yeah? I don't think so, but there has been comparison of surgeons compared to other specialities and surgeons compared to the general population. And I think that we have the same results, that surgeons in general are more agreeable, perhaps conscientious, and less neurotic. Overall, but
you could guess.
I could guess, but there are quite a few studies in the field. But I think it's a question of in which country you live as well. So it's not. This is the Swedish studies, so the Swedish results.
You've opened a new door with this.
We'll see.
Congratulations.
Thank you.
Big hand. Okay, Maria Melke Michel. Please come up and take your first presentation, which is mesh versus suture repair for small umbilical hernias in adults. Early results from a randomized controlled double-blind multi-center trial.
Thank you, Torsten, for the presentation and for being here. And thank you, I'll kill you later, for setting the standard for native English. All right. So I will present the summer trial, a randomized controlled multi-center trial. And this is my disclosures. When it comes to umbilical hernias, today we approximately perform 4,000 operations annually in Sweden, and the majority is under 2 centimeters. And the optimal repair method for the small umbilical hernias with the best short and long-term outcomes remains debatable today. The choices are many. For instance, is it necessary to use a mesh in the case of mesh repair? Is it perform patch better than a flat mesh? And is it really easy to perform when the defect is small? So there is no gold standard technique yet for small umbilical hernias, and we have high recurrence rates with suture repair in the literature, up to 20%. And we have limited level of evidence, clinically still a very common surgical procedure. And the guidelines said that we can recommend mesh today for umbilical hernias over 1 centimeter, although still weak recommendation. And still no consensus about whether to use mesh or suture repair for umbilical hernias under and 2 centimeters. So this was the rationale behind why we conducted this trial called the summer trial, looking at the difference between mesh and onlay mesh, 4 by 4 centimeters, with a suture repair under it against traditional suture repair in small umbilical hernias. Primary elective one with a defect under and 2 centimeters. So it's a multi-center with 6 surgical units. It's a double blind, and we included patients over 4 years. So why use a 4 by 4 centimeters onlay mesh? We think it's an easy method. It will increase the usage of mesh by surgeons with a less subcutaneous dissection, less surgical site complications, and also increased scar tissue to restrain recurrence. And the outcomes of the study is recurrence at 3 years. The secondary outcomes are surgical site occurrences at 30 days and also chronic pain at 1 year. And today I will present the early results for the 30 days. So we randomized 290 patients for either mesh repair or suture repair, and 279 were left for analyzing 30 days. 86 surgeons performed the operations, and it was same at both arms, and it was approximately, I think, 60% consultants and 30% residents in both arms. They were healthy, and there were dominating men that underwent the repairs. The median age was 59, and the BMI was approximately 28. So the results point at, we had overall surgical site occurrences, 58 patients had of 279. There were slight more in the mesh repair group, 32, compared to the suture group, 26. And this is the definition of all Clavien-Dindo 1 and over, just having it. But if you look at the Clavien-Dindo over 2 and 2, if you needed to give some antibiotics or do some kind of bedside interventions, more clinically significant complications, we only had 6. And it is more in the suture repair group than in the mesh group. Only 1 had a 3A Clavien-Dindo with a bedside intervention. The analysis didn't show any significant between the groups for the occurrence of surgical site occurrences. So, conclusion. This is actually the first RCT that provides high-level evidence of mesh repair in small umbilical hernias under 2 centimeters. And onlay repair with a 4x4 centimeters mesh have a low rate of intervention-needed surgical site complication, and we consider it comparable to suture repair regarding the risk of surgical site occurrences. And what does this mean? I think it means that we have done a scientific investigation of a method that is easy and alternative mesh repair for small umbilical hernias that can immediately be implemented in a clinical setting. But the future of the long-term follow-up will determine if there is a reduction in recurrence rate. And also, the results can arise reflection of are we heading a paradigm shift? Will it be mesh on all abdominal wall hernias, regardless size and location? Thank you.
Thank you very much, Maria. Question from the audience, from the floor? You were very, very clear in your presentation, obviously. We had a good lecture just before lunch with the environment aspects of doing surgery, and Nicole Bouvier talked about not operating is maybe the best investment for the environment. How do you perceive the strength of the indication in these patients? Can you tell something about that?
Yeah, well, the indication were quite simple and very alike how you would do the indication if it was not a randomized trial or trial at all. So if you had a patient with symptomatic from their umbilical hernias, you will provide the patients with a surgery, and then we presented that there is a study and gave them information about the study. So the medical indication went on prior the trial inclusion, always. And I always said that to all the site investigators.
Mm-hmm. From your personal view, do you think that there is, are we operating too many umbilical hernias or too few?
No, I don't think we operate too many. I think we're quite conservative in Sweden when it comes to indications for surgery.
Good, yeah. Excellent. Here was a question, Andreas.
Yes, thank you, Maria. Nice presentation. I just had a question about the study setup. You had 86 surgeons and 290 patients. How could you tell us a bit more about the study design and how you conducted the study?
Yeah. So I think you can look at it in two sides. I think it's a strength. We wanted very many surgeons to be performing this kind of repair because we think it's an easy repair. You can apply. Actually, it's like see one, do one, teach one, I would say. So we want every resident to know this kind of repair. Every site investigators and site were educated with the technique and how we would perform it. We had a video also demonstrations. And I think it will increase the external validity and it will strengthen the implementation in clinical settings when we had so many surgeons involved and with few complications.
It was a mix of experienced hernia surgeons and...
Yes, it was 65% consultants and 35% residents, and it was equal in both arms. Yeah.
So the word I would use for that setting is probably a pragmatic setup, that you have a pragmatic use of the resources. And that's, of course, a trade-off. If you do it very precisely with some surgeons, you get something that is generalizable if you have the experts section. But you're right. Good. Thank you very much, Maria. You'll come back. You'll be back. Okay, we go to Uppsala. Malin Enblad, welcome up. And now we're going to tumor markers. And the patterns of preoperative tumor markers can predict resectability and prognosis of peritoneal metastasis, a clustering analysis. So we are going from small umbilical hernias to peritonectomy.
Yes.
Yeah.
So thank you for the opportunity to present this study on cytoreductive surgery in hypothermic intraperitoneal chemotherapy. My name is Malin Enblad. I work at the colorectal HIPEC unit in Uppsala. So this study on the HIPEC patients concerns the major problem of resectability. So in the reported materials, we have 20 to 30% having an open-close laparotomy. And this is patients accepted for cytoreductive surgery. And even these patients who have a seemingly successful treatment, the prognosis is very hard to predict. We have prognostic scores, but they are based on the tumor burden with peritoneal cancer index, the completeness of cytoreduction with the completeness of cytoreduction score, and the histopathology. And these factors are not known before surgery. But what we do have is these 5 tumor markers, and you know them. Some of you use them daily with breast cancer or colon cancer. And we have been taking them for all these years with HIPEC, but we don't use them. And that's been a frustration for me. And we look at them and see, oh, this looks good, this looks promising, but what does this mean? You have a high CA99, and this, I don't know, and this does not look good, but it doesn't change anything. So we wanted to do a new approach with this, so we tried a clustering analysis. And the aim was to investigate if we could see patterns of tumor markers, and by this help us predict open, close, or prognostication. So we analyzed pseudomyxoma peritonei patients, PMP, and colorectal peritoneal metastasis patients in Uppsala. They were all accepted for cytoreductive surgery in HIPEC, and they were treated during this time period. We chose a clustering analysis method called K-means algorithm. And by this method, you can statistically calculate the number of optimal clusters. And these clusters should have the minimal overlap, so they differ as much as is possible. And the results then, we separated PMP from colorectal cancer due to different biology. And you can see here that there were statistically the 2 clusters, one big, cluster 1, and a smaller cluster 2. And when we looked at the pattern of tumor markers in these patients, we had the right one, the pink one, is the smaller one with extremely high elevation. So every row is a patient, and the darker color is percentile from reference. and the darkest color is the 19th percentile. And you can see that CEA is extremely elevated, and CA74 is also extremely well elevated in these patients. And when it came to survival, we also find a significantly poorer prognosis in cluster 2. And this is a poor prognosis for PMP. And we also found that the peritoneal cancer index was extremely high with this tumor marker pattern. With 36, the maximum is 39. So an open-close frequency was also on 43%. That's a lot. So we had significant differences for all these. We also saw differences in histopathology. And on colorectal peritoneal metastasis, we found also that 2 groups differed, and they also had the same pattern with these extreme elevations of all these tumor markers, except for CA15-3. And the survival was significantly poorer in the second cluster, as for the peritoneal cancer index was 26, which is very high in colorectal cancer. However, there were no difference in open-close frequency. In conclusion, I want to say that if you have a patient looking like this, then there's a very high risk that this is not going to work. And I think this should be included in the overall assessment, and also maybe in the information to the patient that this is a high risk, that this is not going to work. I also want to say that CA74 is a very interesting tumor marker. It's peritoneal, and I think that has something for us in the future. CA15-3, I think it's nothing for us. Thank you. Thank you too.
Thank you very much, Malin. Thank you. Questions from the floor? Then I take the benefit of asking something. The K-means algorithm. Are you familiar with?
Yes, I've done it.
You've done it yourself?
Yes, actually.
Impressive, impressive. It's quite a complex mathematic thing, but it was you could use it yourself.
Yes.
That's impressive, really.
You repeat it 10,000 times, and you can choose it to have the repeated result. So I have not done it 10,000 times myself, but the computer.
So it's almost some kind of AI thing to explore the material in different angles.
Yes. So you compare every tumor marker patient with distance between each other from a point, and then you change the point starting 10,000 times, and then this will be repeated, and the least difference between the groups are created.
When seeing your data, my billion-dollar question would be, would you avoid even try to operate on patients on patterns that you consider unfortunate? Have this changed your practice in terms of what patients you put on the table?
So these results, I think, strengthen our gut feeling now that this is not going to work. But in reality, we do have pseudomyxoma peritoneal patients here that wasn't open-close, and some survived after 5 years. So you can't be strict. I think it's, as always, the comorbidity, radiology, in combination with this picture, especially for pseudomyxoma.
So you have the association, but no, how do you proceed now?
I think that if we have, I think this mainly will be in information to the patient. We always say this can be an open-close. Okay. But now I think we will say, we think that this is a very high risk, but we will try this for you. You are young. We want you, but you should know that this...
It's a piece in the puzzle.
Yes, it's a piece in the puzzle.
Thank you very much. Thank you. You're not... Okay, good. You're not allowed to sit for long, Maria. It's time again. It's time again. Maria Melke-Michel, a surgical unit volume. Quite some sensitive topics here that's brought up in this session. Surgical unit volume and reoperation for recurrence following total extraperitoneal TEP. I would say, a nationwide population-based register study.
Okay.
Please.
Thank you again, Torsten. This time I will talk about a population-based register study from the Swedish hernia register following TEP groin hernia repairs. So this is my disclosures. So we asked us what is the minimum amount of performed TEP repairs per year for an acceptable rate of recurrences. And especially, how well do we perform TEPs in Sweden today when it's increasing in the hands of many general surgeons? So we conducted a study looking at primary aim for reoperation for recurrence after following TEP groin hernia repairs that was undergoing surgery between 2015 and 2019, and looking the difference between high volume surgical units and low volume surgical units. So why surgical unit volume? Well, I can already say that we have limitations in studying surgeon volume in the database. And the hypothesis was that high volume surgical units can provide less experienced surgeons more opportunities, resources, volume, which can lead to lower rates of recurrences and better patient outcomes. The study is a nationwide population cohort from the Swedish hernia register. We have a national coverage since 2004. Almost 100% of all hernia repairs are registered prospectively. So it's a highly validated register with very many repairs. So we had over 20,000 TEP repairs during this study period. We only excluded emergency repairs. There were like 300. We have 75 surgical units, and we categorized them in 4 categories. The low volume, if they did under 12 TEP per year. The low medium, 12 to 50 per year. Medium high, 50 to 150. And the high volume, they performed over 150 TEP repairs per year. So, how low can we go and still have acceptable low recurrence rates? As you can see, the red curve is the low surgical unit volume. And the very, very blue one is the high volume, and those are between. And although this is not an adjusted figure, you can see that there's quite difference between the reoperation rate for recurrence between the low surgical units and the high surgical units. And performing a Cox multivariate regression analysis and adjusting for confounders, you could see that the total reoperation rate were 2.9 in the high volume, and they were quite increased in the low at 5.3 in recurrence rate and 3.8 in the low medium. They had an increased hazard ratio that was significant in the analysis, putting a line there between that. It seems that 50 TEP repairs per year is a number to remember. So, conclusion, to answer these 2 questions in the beginning. What is the minimum amount? Well, in this cohort, we can actually see that there were a significantly associated increased risk of reoperation for recurrence in surgical units with less than 50 repairs performed per year. And how well do we perform? Well, I will say overall quite well, as you can see the numbers at 3.3 recurrence rate, but however, unsatisfactory high recurrence rate over 5% for low surgical units in modern time. And there were actually 25 of the 75 units that had these results. So what does this mean? Well, I think these findings may influence guidelines on required annual surgical unit volume to improve patient outcomes following TEP repairs. And I also think that controversially, it will arise as reflection of groin hernia repair centralization, and also how about early laparoscopic groin hernia repair in our education. Thank you.
Thank you again, Maria. Questions from the floor? Magnus, welcome back from Oxford.
So congratulations to a nice presentation. Is it really the volume per center that is important for this type of surgery, or is it per surgeon? I mean, for major surgery, it's the ability for a center as a whole to rescue, but for this type of surgery, wouldn't it be more interesting to look at surgeon volumes?
I totally agree that it's very interesting to look at the surgeon volume, and there has been some attempt to look at the surgeon volume also for that, but today we actually have a limitation in the database to look at the surgeon volume. We still believe that the surgical unit volume can provide information of the relationship between volume and the outcomes after TEP and the recurrence. And we believe that high volume surgical units can provide this kind of volume, resources and experience and get more surgeons to that unit so we can have better patient outcomes.
So you believe it's kind of a proxy for surgeon volume?
It can be.
Okay.
Maria, can I ask you, how did you come up with the number of 12?
Yeah, the categories, yes. So we looked a little bit in the årsrapport before, how it looked like in the surgical units. And we saw that there were many units actually doing very few TEP repairs per year. And we thought a number, if you did one per month, this is elective, not emergency. We wanted to highlight those very low surgical units because we had a theory that they were probably having higher recurrence rates. That was our hypothesis.
If I'm playing a little bit of the devil's advocate here with this, because you're quite strong in your conclusions about that there are better results, and I can agree that it looks with the data, but aren't they associations for the moment?
Of course.
So maybe there could be, yeah, but I just wanted to bring it up again, that it maybe have a little bit about, there might be confounders in this. Low volume especially, those centers, they are standing out. And a question, do they really have the same mix of patients that, the same challenges as the high volume?
Totally right. We are very, I'm very corrected with my language. I also said it was an associated increased risk that we saw because it's a register study. There were differences in the baseline when it comes to different patient groups. And we did consider all those kind of variables and adjusted them in the analysis.
Good. One short from Linus.
Okay, Linus Saxon, thank you. The units that are doing hernia surgery in Sweden today are different than 5 years ago and 10 years ago. Today it's much more units that are either private or many of them are private and they don't have education. And I think many of those high volume surgeons are working in a private setting with no education. How do you think this will have implications on education for hernia surgery, and do you think that's one of the reasons that the high volumes are doing so well?
It could be like that. In this material, in this cohort, still there were like, I would say 95-98% just consultants that did the repairs. We still don't have so many under education that are actually performing laparoscopic groin hernia repair. So it were equally in all groups, as you can say. But in the future, I think that we should involve more laparoscopic groin hernia repair in the education, early in the resident education.
Okay, we need to move forward. Thank you, Maria. Okay, we are changing subject. Kim Gullis, welcome up. You're going to talk about definitely another type of design of the study, and we're looking forward to hear about a prospective longitudinal cohort study of health-related quality of life by type of breast surgery in women with primary breast cancer. Floor is yours.
Thank you so much, and thank you for this opportunity to present my study. The title has changed slightly of BJS Open to Health-Related Quality of Life by Breast Surgery in Women with Primary Breast Cancer, a prospective longitudinal cohort study. This was a part of my thesis, the last article I made, and the aims of this study was to look at prospectively the quality of life in women with breast cancer who underwent primary breast surgery. And we looked at different quality of life questionnaires, BreastQ and QLQ-C30 and BR23. We included 340 patients over 2 years in our hospital, and all but one patient came to the 1-year follow-up, and that was due to the patient was deceased. We divided the patient into 4 groups: the oncoplastic surgery group, a partial mastectomy group, a pure mastectomy group, and then a mastectomy with reconstruction group. And all of those were made with implants. We divided the group based on the surgical codings. In the first table 1 here, we can see that the age of the different group varied slightly, with the mastectomy group having a slightly older age and the reconstruction group being slightly younger, which was to be expected. We can also see that the mastectomy group had a slightly larger tumor size, and that the reconstruction group had the highest amount of reoperation, which was mainly due to bleedings. If we look at some of the results, this is the BreastQ difference in each patient between the post-operative 1-year questionnaire versus the preoperative score, which means that above the 0 is a better satisfaction with their breast after 1 year, and below the line is a worse satisfaction. And here we can see that the oncoplastic surgery group and the partial mastectomy group were more satisfied 1 year after surgery. If you look at psychosocial well-being, we could find no relevant differences between the groups. And when we looked at sexual well-being, there was a trend towards the mastectomy group being a bit less satisfied 1 year post-operatively. Then we looked at the pure post-operative scores of BreastQ. And here on the left side is the physical well-being chest. And this score is reversed, so 100 is the best score in this one. And you can see that the mastectomy group had one of the highest scores. And when we looked at effects of radiation, which the patient only answered if they had radiation, we can see that mastectomy and reconstruction had a lower score compared to the other groups. And when we looked at the QLQ BR23, which is also a breast cancer specific questionnaire, in regards to body image, the oncoplastic group and partial mastectomy group had a better outcome. And in regards to symptoms from the breast, the mastectomy group had a lower amount of symptoms. And sexual functioning, again, we could see that mastectomy and reconstruction had a lower score. So the results of this study was that partial mastectomy and oncoplastic partial mastectomy had better outcomes in terms of breast satisfaction, body image, and sexual functioning. There were more breast symptoms in the oncoplastic and mastectomy with reconstruction group, and interestingly, the group with the least symptoms from the chest area was the mastectomy group. Thank you so much.
Thank you very much. Very clear and straightforward presented. Can we have questions from the floor? There's, yep, Jenny.
Thank you for a lovely presentation and an interesting topic. What would you say is the main difference between the oncoplastic surgery and the regular PME in this cohort?
In our cohort, we chose the surgical codings, but in our center, this really means that partial mastectomy is when you do a straight incision over the tumor, remove the tumor, and just close the glandula and the skin. So anything that's any kind of reshaping of the breast, we call that an oncoplastic surgery.
Thank you.
Any other question? My question is, how has this work affected your practice, daily practice in Kristianstad or?
So far, I mean, Kristianstad has a very long tradition with our senior surgeons to do a lot of breast-conserving surgery. This only strengthens our feeling and our idea that breast-conserving surgery is better for the patient, not only for how they look, but also how they feel in regards to quality of life. So I don't think we've changed that much, but I think we're going to continue the work of trying to do as much breast-conserving surgery as possible.
There might be other centers having other opinions about this,
yes.
and what would be their criticism to your material, and how can you, if so, what could you do to?
I mean, a multi-center study would of course be a better option in this case. We would like to do a bigger study on it, because in our center we are a small center, but we do very similar work, how we choose our patients and what kind of reconstruction we do, especially with the breast-conserving surgery. But of course a multi-center study would be a better option in the future.
Would it be possible to some segment of patients doing a randomization? Would that be possible?
We've discussed this. I think it's difficult, because so far that we've come with the breast surgery today, I feel like if you tell the patient that we think doing some kind of reshaping of the breast is better, it's hard to tell them to do a simple surgery when something more complicated is better. So I think it's a hard decision. Maybe in some selected, for example, with the mastectomy and reconstruction, there are some possibilities to do a randomized. But when it comes to partial mastectomy compared to oncoplastic, I think that's a difficult one.
So it's a piece in the puzzle.
It's a piece in the puzzle, of course.
Good. Thank you very much.
Thank you.
So now we have come to the last contestants, which is Per Nilsson from Stockholm, Karolinska, presenting on surgical outcomes following total neoadjuvant therapy in rectal cancer with short course radiotherapy using protons or photons. Safety data from the first 20 operated patients in the randomized PROTECT trial. That was a good study name.
Yes, it's appropriate to start with an apology for the very long and inconvenient title, but I will try to improve during the talk here. So the PRORECT trial is a Swedish randomized ongoing trial in locally advanced rectal cancer. The primary outcome measure in that trial is grade 3-4 toxicity measured preoperatively. The design of the trial builds on the total neoadjuvant therapy arm in the previously published RAPIDO trial. And as you can see, patients that fulfill the inclusion criteria you see here are randomized to either standard intensity modulated photon radiotherapy or to proton beam therapy. After that, they receive their neoadjuvant chemotherapy before they have a response evaluation. And contrary to the RAPIDO trial, patients now that have a clinical complete response can come into an organ preserving watch and wait program. But this report today focuses on the Stockholm patients that have gone through the entire treatment, TNT treatment, and then had surgery. Obviously, you have to ask yourself, why should we use proton beam therapy? And these pictures are from a previously published paper from our group. And this is patients receiving conventional photon radiotherapy, and this is proton beam therapy. And even though we're all surgeons, we can see that there are dosimetric differences, and there is reduced amount of irradiation to organs at risk. And this is supposed to translate into less side effects. There are, though, still uncertainties with proton beam therapy. We don't know everything about the relative biological effectiveness. We don't know everything about the beam range and dose distribution. And perhaps most importantly, there is almost a complete lack of evidence for proton beam therapy in the neoadjuvant setting. And that's not just for rectal cancer, that goes also for esophageal cancer and other types of cancer where you use neoadjuvant radiotherapy. So by January this year in Stockholm at 2 hospitals, we had 10 patients in each arm that had gone through the entire program of TNT and then surgery. And as you can see from the patient and tumor characteristics here in this table, the patients were very similar. We also wanted to look at overall treatment time because that is important when you have an extended regimen like this. And there was a great similarity between the two groups with respect to OTT. Then looking at the surgery that was performed, you can see that 17 out of these 20 patients had robot-assisted surgery. There were 5 patients who had a low anterior section, 5 who had an abdominal perineal excision in each group. And there were a few patients that had what we call beyond TME surgery, that is extended surgery. So for instance, in the proton group, there's one patient who had a full pelvic accentuation. Lateral pelvic lymph node dissection was an uncommon event. I would say that there were no clinically relevant differences in operating time or blood loss. Complications occurred, were very common. Almost all patients experienced some sort of complication, but there was no clear pattern in any obvious differences regarding complications. An observation in this small series, there were 10 patients with an anastomosis. There was 1 patient in each group that had a severe leak with reoperation and prolonged length of stay, and there was 1 additional leak. So 3 out of 10 patients had an anastomotic leak. Then looking at the histopathology of the resected specimens, perhaps there in the middle you see the R status, and it's very nice to see that almost all patients had an R0 resection, which is of course a key to success in rectal cancer surgery. A little bit speculatively, but if you look at the YPT0, YN0, and the tumor regression grade, you could sort of, are protons more effective than photons? Because you see there is a tendency to a good response. One thing that a comforting finding in this report, in this early report, is that there was a good quality specimen in almost all patients, and that has been a bit of a concern in the Rapido trial. So this is a good finding in that aspect. So in conclusion, it's obvious for anyone that there is a limitation in the sample size here, but if we remember that patients are randomized, I think it's justified to compare them, although the sample size is very small. Our interpretation is that proton beam therapy does not disfavor patients. And with this, we think that continued recruitment to the trial should be encouraged, and new centers across Sweden are very welcome to join. Thank you very much.
Thank you very much, Per. Are there colorectal surgeons or others who wants to ask a question? There's a microphone out there.
Crystal clear.
Absolutely, absolutely. Is there anything that, from a cost perspective or others, that would make photons or protons more preferable? Is there something? If you could you just pick any one of them from results, what would you choose?
Yeah, I mean the cost aspect should absolutely be discussed, but you can view that from different aspects. I mean, our country, we have now jointly invested in the Scandion Clinic in Uppsala, and then we should use it. We should use it for research purposes, and the money is invested there. So, but then what the future will be, I don't know. They've opened a proton center in Denmark. They are building 2 facilities in Norway, and if we can show that there is a patient benefit, perhaps we should invest more in the future, but that is, we have to do this kind of scientific evaluations firsthand, of course.
Mm-hmm. Just a practical question. Was it difficult to recruit patients when you talk to them?
No. My experience is that patients are very open. And since it's only 5 times 5 gray, it's 1 week of treatment. So leaving your home, spending a week in Uppsala, if you haven't been there, you should go to Scandion and visit. It's a very nice facility.
Uppsala, I thought you said.
Uppsala.
Yeah.
It's a very nice facility. They have a hotel, very good food. So most patients are very positive to spending a week in Uppsala to get their radiotherapy. Then they get their surgery, they get their chemo in their home hospital. So recruitment has not been difficult. As of now, we have 86 patients in the study, and the target is 150. So we are hopeful, and the progress is improving.
I can see you're doing a good job of selling in Uppsala for the tourist companies in Uppsala. I would be very happy for that. Thank you very much, Per.
Thank you.
So everybody, the moment of truth. There are only 2 prizes and 6 presentations. And first of all, I think we all agree that we just give a big hand to everybody for the extremely nice presentation we have had today. But we have to choose a winner or 2. And if we take the next slide, we have the second prize winner, which is 1,500 euros. And the second prize winner is Kim Gullis. Welcome up. Thank
you so much.
Thank you. Can I? Yes. I'm a hugger. Please stay, Kim, because there's a motivation also that authors have addressed a very relevant patient-related question in the treatment of breast cancer and followed patient in a county hospital setting. The paper is well written and the results are highly relevant and may immediately influence clinical care. Although you're doing it already. Thank you very much. I think we take a small fanfare there too. We do that. A fanfare for... And friends, even more moment of truth. Now it's coming to a conclusion. Can we have some drums? Sweden, we have a result. The winner is Maria Melka Michel. Welcome up.
Thank you. Thank you.
Congratulations.
Thank you.
Congratulations.
Thank you.
After you did the most work for it. You did the most work for it. But we have so it's you had 2 of them. So we have to be clear that it's about the mesh versus suture repair for small umbilical hernias in adults. Early results from a randomized controlled double-blind trial. And the motivation is a first outcome paper from a well-designed and well-executed randomized controlled trial. The paper is nicely written and delivers a clinically relevant information, although not presenting the primary endpoint. So where will it be when the primary endpoint? Congratulations for this.
Thank you.
Thank you everybody for coming here. That's the end of the section. Congratulations to all the presenters. Thank you.